Okay, so just starting off, Ali, thank you very much for joining me today to talk about the emerging integrated care systems landscape within the NHS and the potential role and opportunities which exist for accredited specialists within occupational medicine who work specifically within the NHS environment. Today's session, we're particularly keen to draw upon your own lessons learnt and experiences working within the ICS landscape, so we can offer some helpful tips and advice to others who work within the specialty. So to start with, Ali, I'm quite keen. Are you able to give us some background information about the purpose and role of integrated care systems within the NHS?
Yeah, sure. I think just to put it in a nutshell, the integrated care system are a way of combining the sector in terms of service delivery. So, as you know, if you look at the history of NHS, there has been multiple changes in terms of the unit of service delivery between hospitals, statutory health authority, trusts, then SDP, and now ICS. So it is basically a new way of combining those service providers to maximize efficiency, obviously in the face of very limited resources. I think you probably know, I don't know when this is going to be published, but at the moment it is still being discussed. I mean, technically, as far as I know, from a legal perspective, the legislation is lagging behind. So once the legislation come forward and it is implemented, we will know more exactly in terms of the legal standing of those organizations. But as things are, the plan for ICS is to have a joint approach to service delivery, and it's not just in terms of the front line. It's also in the back, or what is called back office, things like finance, HR, occupational health, those kind of support services for the front line is also going to have a more sort of joined up approach between different organizations. I keep it very brief because, as I said, I mean, things may change when it becomes legal, when it's implemented, especially as it goes through different sort of tranche of consultation. But in a nutshell, it is a more of a sort of a combined approach, if you will.
Okay, that's really, really helpful to just, I guess, set the scene for what's currently happening across the wider NHS environment, and certainly what opportunities exist for occupational medicine and those who work within the specialty. So just thinking about the role, what role do you think accredited specialists within occupational medicine play within the ICSs, and how can their involvement within the ICSs bring benefits to NHS OH services and also to the wider NHS patient community?
I think probably the answer starts with the benefit of having access to accredited specialists in an NHS organization. And as that organization grows, let's say from a small DGH to a trust to ICS, that role naturally grows with it. There are lots of conversation and lots of views on what the role of an accredited specialist should be, and it will certainly be affected by local demands and local availability. But generally speaking, what I think an accredited specialist should be able to deliver is that strategic leadership at the start of it. I think obviously the technical skills and ability to run a clinic is a must. However, the way I look at the accredited specialist is their management and leadership and the ability to not only lead internally in terms of the occupational health service, but also provide that leadership and a strategic view to the trust, and then at a bigger scale to the ICS. Just slightly sort of going further, but what I mean by leadership is basically making decisions or providing expert views on what we normally do in occupational health, like staff rehabilitation, staff retention, health and well-being, health surveillance, but also being influential in terms of making those decisions. So a good example, for example, as is happening now, is the mandatory vaccination. And there are a lot of facets that can or may overlap with occupational health. And as you talk to colleagues around the country, you see how many different approaches have been adopted by different organizations. And you can see colleagues who've basically stuck in and provided that leadership are totally moving that sort of mandatory vaccination in a different direction. So I think it is not just about technical skills, which, as I mentioned, is an absolute core, but it's about about leadership and about the management, but also internally within the OH and also externally with the trust. Also, I would say there are areas that perhaps historically we have not particularly been active, but are very much within our skill set. For example, since COVID has started, everybody's talking about risk assessment, but it is actually a way of management. Risk-based approach to any question is a way of management. And perhaps if you look across all different specialties, occupational health is best placed because on an everyday basis, we deal with risk assessment. So I think using those skill sets and trying to bring it up into what the question of the day is certainly what I look at from an accredited specialist. I mean, I mentioned a few times the technical skills are at the core, and I just want to reiterate on that. I don't want to dismiss at all the technical skills, and there are questions that only specialists can answer. I mean, again, there are lots of conversation whether something should go to a specialist or not, but certainly things are like medical legal aspects to it, potentially litigation, potential pensions, very small things like clearance of healthcare workers who live with bloodborne viruses. These are things that, in my view, can only be dealt with by a specialist or under direct supervision of a specialist. The reason I mentioned that is we are going to have, or that's my personal view, I might prove wrong in the future, but I think there is going to be an increasing number of litigation, whether it is because of mandating the vaccine, whether it is as we get more and more long COVID and people cannot come back to work, was it work-related or not, become an issue. So I think there will be an increasing number of questions that an occupational health is best placed to answer in terms of work-relatedness, rehabilitation, impact on workability, and so forth. So I think that's another part of technical skills.
Okay, that's really, really helpful. Thank you. And I guess you've highlighted, I guess, some useful practical examples. So just thinking again, in light of using some practical examples or drawing upon some of your own experiences, can you describe how the role of accredited specialists within occupational medicine might function and work in practice within the ICS landscape?
Yes, so in terms of going to more practical, I mean, typically I would divide them into two streams, if you will. One is what occupational can do proactively and what can be done reactively. Historically, the majority of my colleagues, especially the medical side of occupational health and the specialists, are very much into rehabilitation side and reactive side, i.e. you deal with sickness absence, ill retirement, and so forth. However, there's been an increasing opportunity in terms of health and well-being, obviously starting back in 2009 and 10 with Carol Black's review and then Dr. Steve Borman's review. And then it gradually gathered momentum in 2015 with the sort of start of looking at NHS sort of 5-year plan. And then COVID obviously basically brought it home in terms of health and well-being. And I think that is one area that I think I use as the best example of where a specialist in occupational medicine can help, especially at the ICS level. There are lots said about health and well-being, but actually there is little substance beyond typical physiotherapy, smoking cessation, doing a bit of a Zumba class. It's just actually the concept and the strategy that you would expect, and you want to make sure that you're not necessarily offering everything that everybody wants, because it can potentially be something under the scope of health and well-being. But equally, you want to make sure that you provide things that are evidence-based, have a proven record. Also, you need to be mindful of evaluation. I think that one of the one important part of any health and well-being program is to be able to evaluate it. And again, this is a very murky area. I don't necessarily mean to prove by pans and penny that you evaluated and it proved you saved money. When it comes to health and well-being, there are a lot of occasions that it's very difficult to actually monetize your output, and you have to have a broader sense of evaluation. The whole point I'm making is there is a huge opportunity for our colleagues as accredited specialists to get involved in health and well-being, and don't just let it go by HR or people are interested but without any informed knowledge. I haven't talked about training as yet, and I'll come back to that, but a big part of training in occupational medicine is health and well-being, is health promotion. So I would expect any of our colleagues to have adequate and sufficient skills to get involved in that. Now, when you talk about a trust, it's probably relatively straightforward in terms of health and well-being. I say straightforward in the sense that you probably know your stakeholders, you know what is available, you know the resources, you know what is your quick win and what is your long-term plan. ICS provides a different challenge, but also a different opportunity, like any other wake of life. So just give you an example, even in our sort of sector, when you look at ICS, we have a huge discrepancy and inequality in terms of health and well-being offer. So at one end, you have trusts like ourselves that have a very robust 6 or 7 figure sort of program of health and well-being, and at the other end you've got small GP practices or small social care homes that have absolutely nothing. They don't even have a hepatitis B vaccination program, and that's the inequality, and that's the challenge, but equally the opportunity to actually look at the good examples, look at areas that are in desperate need, and decide what is the best way to help everybody and bring it up to up to kill, or leveling up, as it's a sort of buzzword nowadays. So I think that that's a huge opportunity at ICS level to use health and well-being and use the health and well-being the occupational medicine expertise to promote health and well-being. On the reactive side, I think most people have been involved in this for decades now. I don't have a particular sort of message to add to that. I think one thing that probably I hope will happen, not necessarily at ICS level, perhaps at even larger level, is although NHS is one employer, one massive employer, 1.3 or 4 million people working for it, but actually is divided into very small companies. So we all do our rehabilitation, we all do our HR management in our own. So although there is a national contract, but there are huge variation in terms of how you rehabilitate somebody, what is available to you. A simple sort of message, for example, is phased return. I mean, different trusts have different definition of phased return, different support mechanism, different sort of duration for it, and all sorts of different local decisions. Whereas I think there is a bigger opportunity if we go to say ICS level, and if we sort of agree a unanimous definition, it makes everybody's life easier, but also gives you a better opportunity to, if you're looking for alternative duties. I know it's wishful thinking, probably not going to happen in my lifetime, but for the sake of argument, if you're allowed to redeploy somebody from trust A to a trust B within the ICS, that gives you probably twice the size of rehabilitation, if you will. It never happens. It's not possible because of the way NHS is set up. But if ICS become one organization legally, then technically you can move people around, and it makes it a lot easier. So that's just one example that the opportunities that might be in the horizon when we join forces. I think I don't know if it's in your question, so I don't expand on this unless you tell me to do so, and that's about training opportunities.
Yes, please do.
Okay, I'll come back to that. And the fourth one, I think, is about our limited resources. I started the last one because that's probably more important. I mean, we are under no illusion. We are facing a huge crisis in terms of occupational health practitioners, and it's across the board. It's not just specialist doctors; it is doctors and nurses alike, and other healthcare professionals. And you may know that from a national school point of view, we've been working hard with input from DWP and all other stakeholders to see how we can address the crisis. And I hope we can solve it, but this is a long-term plan. We can't just come up with a plan and next day have 1,000 doctors or nurses in occupational health. Whilst we're facing that very challenging environment in terms of lacking adequate occupational health practitioners, one way to deal with it is join forces and try to share the resources we've got available. So, for example, us in Guy's St Thomas's, we're supporting probably about 4 or 5 different NHS trusts at different levels. And I know other colleagues do the same. Those who are more fortunate have more doctors in their team or more nurses in the team they're supporting locally. When you move to the ICS, that basically gives you hopefully the structural backbone to actually do it in a more formal way. So if you don't have access to occupational health specialists in every hospital, but if you do have an specialist sitting at the ICS level, that person can support the whole ICS system. So I think there is a huge opportunity just as a short-term measure. I don't want to be clear, this is not a long-term treatment, but as a short-term measure to share resources at different levels through the ICS. It's not just about human resources, it's about technical resources as well, and also administrative resources. So for example, it just give you an example. I go to probably about 4 or 5 different trusts, and all of them at the same time are developing policies and different things. And if you look at it, it's just wasted time, because why we need to have 5 different TB policies or 5 different COVID policies or 5 different health and wellbeing policies? They're all the same. If one develop it and put it at the ICS level, it becomes an ICS policy, and then you can save some time. The same goes for pre-employment, for example. I mean, it's just barking mad that we do a pre-employment for people working or moving within the NHS, whereas we've done exactly the same in one hospital. We just go on to repeat exactly all of them again when they move to hospital B. So there are lots that you can save if you move to a bigger level. As far as training goes, again, one of our biggest challenges, we have not trained enough doctors and nurses in occupational health. There are lots of drivers for that, which I'm not going to sort of bore you with. One of the reasons that we do not have enough trainees is we do not have enough supervisors. So there are places that they are desperate to have a trainee. We can potentially conjure up some funding, but there is no supervisor. Whereas when you join up forces, the same as I described in terms of sharing resources, you can actually use those supervisors at the ICS level and perhaps create more training posts who are supervised at the ICS level. You still have to have clinical supervision on a day-to-day basis, but that's relatively straightforward to arrange. But the more robust supervision, the educational supervision can be done at the at the ICS level. So again, there is another benefit if we have larger sort of organizations from an occupational health perspective to share those resources as well.
Okay, that's really interesting and useful advice, Ali, in terms of how accredited specialists can work within the ICS landscape, but also exploring some of the broader issues that are impacting on the specialty itself. Just finally, I'm quite interested to get your views or to see whether you're able to offer any useful tips or advice to our colleagues within the specialty who are particularly interested in exploring new collaborations within their local ICSs. And what would you recommend they do in terms of next steps from a practical level?
Sure. I think I don't necessarily call it tips. I don't feel particularly ahead of the game to give people tips. What I would suggest is the way we dealt with it. I'm probably sharing experience rather than giving tips, and people can decide and choose what they want to learn from it. I think probably the most important one is engagement and making sure that one, who are the leaders or the drivers. So it's typically run by HR people, but it might be different in different areas, and who is the person responsible for what. So you have to remember that there are different parts of ICS. It's not just about occupational, it's not just about HR. There are different sort of streams into that. So I would say probably understanding the landscape, knowing the players is the first point. And the second point is, if you are lucky, as we were, you're already in touch with those people, you have a slightly easier job. If you're not in touch with them, it's slightly more difficult, but still the message is the same, just trying to engage with those people. It is staggering how people who are in charge lack knowledge about occupational health. Most of them still don't understand that the occupational health is actually funded locally, not nationally. Most people don't understand the difference between a doctor, a specialist doctor, and a diplomate. Most people don't understand different delivery model in terms of in-house, outsourced, mixed. So there is a staggering lack of knowledge about occupational health within the senior leadership of any level, whether it's a trust, a general practice, an ICS, NHS region, all of them are in the same boat. The other thing is, those who think know occupational health, most of them know it as a manager who referred someone else. So all they know is about the management referral. They don't understand the rest of it. So I would say know the landscape, understand the players, engage with them, and start from very basic. Don't be afraid that you're repeating things that people may know. Most of them don't. And then demonstrate your expertise by example. So there are lots that we've been doing, at least in the past 2 years, outside the normal sort of framework of occupational health. Demonstrate those value you've added, and then if you're able to show the value added, then it's no brainer. They will come back to you and then maintain your engagement. I think these are the 3 or 4 areas that I would highly recommend our colleagues to consider.
Okay.
And one final one, if you don't mind, Vaughan, is also talk to your colleagues as well. It's a very isolated specialty. You all know your colleagues in the neighboring trust and neighboring ICS, but you may not necessarily have talked to them. So talk to them, because some of them might have been already tasked by their HRD or CPO to do something. So make sure that when I say know the landscape, you actually talk to your OH colleagues in the same region as well.
And you certainly highlight the value of shared experiences and imparting knowledge and experiences across our local teams and regional teams as well. Ali, thank you very much this afternoon for your time. I hope the information that you've certainly imparted here today will be useful for our colleagues who work within the occupational health and occupational medicine field. And we look forward to seeing how the evolving ICS landscape continues to create opportunities for occupational health to play an important role within that area as well. Thank you very much, Ali.
My pleasure.
Take care.